technologies are the different technologies that are differently applied in seeking for immunization against the SARS-CoV-2 virus. I would like to clarify, next slide, please, that the thrombotic complications reported have been occurring with the category that is now lined up on your slide deck. So these are the viral vector-based vaccines, or to be more specific, next slide, please, the adenovirus-based vector vaccines that are named the AstraZeneca developed by Oxford, or perhaps a more appropriate term, the ChAdOx1S, S for spike protein. And number two, the second vaccine, the Janssen/Johnson & Johnson, or to use a more technical term, the adenovirus 26 COVID-2 spike. Next slide, please. And reminding ourselves that the vaccination offered to the pediatric population in Canada in children aged 5 to 11, and for, as a matter of fact, 11 to 17, does not include those two. It is the messenger RNA-based one that you see shown on the left part of your slide. That is the Pfizer-BioNTech COVID-19 vaccine. Next slide, please. Next, please. And next, please. So the proper terms, the ChAdOx1S or Ad26 COVID-2S, reflect what the perhaps a greater name explains. These are adenovirus or recombinant chimpanzee adenovirus developed at Oxford, the vector 1, there was a vector 2, against the spike protein, which will cause the host, the recipient of this vaccine, to develop antibodies against the material introduced by the chimpanzee adenovirus in the case of the ChAdOx, or the recombinant adenovirus human-based serotype 26, hence the names that hopefully clarify why, what those terms refer to against the same spike protein. Next line, please. And finally, for us to have a clarification, this has probably been reviewed throughout the program, yes, already, how the viral vector-based vaccines work. There is the process that the virus carrying a cassette with the DNA material incorporated into the virus or the vector that is subsequently introduced into the host cells, and that is what will allow those cells that have now been infected to present the spike proteins, because that DNA will be incorporated into the cellular machinery. Next line, please. Next, please. Now, throughout the globe, this condition, that is thrombotic events following the two adenoviral vector vaccines with subsequently complication of thrombosis and thrombocytopenia, has received different nomenclature endorsed by different national and international bodies. For example, the American Society of Haematology and the Centers for Disease Control and Prevention, and the more global International Society on Thrombosis and Hemostasis, have all adapted the nomenclature vaccine-induced immune thrombotic thrombocytopenia, or VITT. Next slide, please. Thrombosis Canada, obviously the highest national body related to what pertains to thrombosis in our country, and the German Thrombosis and Hemostasis Society initially adopted the terminology vaccine-induced prothrombotic immune thrombocytopenia, or VIPIT. And next slide, please. The British Society of Haematology adopted a nuance of VITT so-called vaccine-induced immune thrombocytopenia and thrombosis, also abbreviated as VITT. This is not an exhaustive review of all the terminology being used in the literature. There is a more general nomenclature that calls thrombosis associated with thrombocytopenia syndromes, TTS. But when we use more general nomenclatures, we will be adding additional differential diagnosis to it. I just wanted to remind the audience of that. Next slide, please. So the typical case scenario that launched triggering of the regulatory bodies in Europe pertained to mostly female nurses that were receiving the adenovirus vector-based vaccination and in whom the thrombotic complications arose. A typical scenario would have been of an early adult female, excuse me, a 40-year-old woman that would have received the first dose of the AstraZeneca vaccine, and around 2 to 3 weeks later would present to her family doctor, who, by knowing her, would know that she was previously healthy, and the typical patient initially would describe blurred vision and headache that was accompanied by severe thrombocytopenia. A normal platelet count depicted within parentheses between 150 and 400,000, and severe thrombocytopenia defined as less than 30,000, and that patient had 20,000. Next slide, please. So hopefully, so that we're all at the same level, we would have a condition of thrombotic complication accompanied by thrombocytopenia, called globally VITT, or in Canada VIPIT, or in the UK, because many of the definitions will continue to be shared now will be coming from the UK, that defines the condition that we're about to get started. The main objectives now that we have around half an hour left will be to review what is VITT, why does it happen, how to recognize it, and how to treat it. Next slide, please. Next slide, please. Let's go through timeline road and review what happened within almost a week time span. So what you see lined up in your slide are 4 different publications that would have occurred between April 9th and April 16th at the New England Journal of Medicine publication headed by Boston/Harvard, and Harvard at Boston, Mass, United States. So you see initial reports of VITT occurring after first vaccinations of the ChAdOx1, and you also see an initial report, all of the AstraZeneca hence, and you see in the mix an initial report of VITT occurring after the Johnson & Johnson/Janssen vaccination. Next slide, please. In parallel, in the United States, we had mentioned early April for the publications to arise at New England. The Johnson & Johnson COVID vaccination timeline, as it had received the okay by the FDA to be rolled over the population late in February, and the vaccination started early in March. Somewhere between March 19th and early April, 6 cases of patients with cerebral sinus venous thrombosis, which is thrombotic complications and occlusion of the venous system in the brain, accompanied by thrombocytopenia, were reported to the system, the national American system called VAERS, which reports vaccine adverse effects. And that was put together with the similar reports that were coming from Europe, to a point that by mid-April, the CDC and the FDA recommended a pause of the Johnson & Johnson vaccination nationally. Next slide, please. At first, after sharing the next 2 or 3 slides with the summary of all the cases initially reported, as I've just shared with you, the thought was this was a rare clinical syndrome occurring approximately 2 to 3 weeks after the first onset of either one of the 2 adenovirus-based vaccination against COVID-19, occurring, as I mentioned, predominantly in females and accompanied by thrombocytopenia, most commonly of the severe strata, and thrombotic events. Of note, the thrombotic events would occur preferably at rare sites, that is the brain or the abdomen, reminding ourselves the most common venous thrombotic events in adults occur in the lower limbs, with a likely case fatality associated between 20 and 40%. But these patients did not have acute COVID infection and likely having a pathophysiology that would resemble what is called autoimmune heparin-induced thrombocytopenia, excuse me, which is a paradoxical response to a heparinoid, which is an anticoagulant, which supposedly protects us from getting clotting expansion. But in as minute percentage of patients, the exposure to heparin leads to a paradoxical effect that it promotes clotting rather than protecting us from clotting. So that's what heparin-induced thrombocytopenia means. Next slide, please. This is a summary of the European report of the initial cases that were published on the New England time span of 1 week. So we have reports from Austria and Germany on column 2, Norway on column 3, and the UK on column 4. A little bit north of 40 cases. We can see the onset post-vaccination spanning from 5 to 24 days on young adults aged as high as 77 with a female preponderance, and the thrombotic sites that were reported more commonly, again, the cerebral sinus venous thrombosis, but also a few other anatomic sites involved in the abdomen, such as the portal veins, excuse me, but also pulmonary embolism and deep vein thrombosis. We can see that platelet count spanning to as low as 7,000 and as high as 113,000. But from a laboratory, additional laboratory perspective, almost all of the cases had a positive screening test for this elusive condition named HIT. That would be the test named platelet factor 4 assay or PF4 assay. And unfortunately, with the severe mortality and occurring from 1/3 of patients to as high as almost 2 out of 3. Next slide, please. Here we see a summary of the initial American cases, now focusing on the Johnson & Johnson/Janssen vaccination. And we have similar characteristics in that the presentation would have occurred between 6 and 15 days. Young adults more commonly, and then of the ones aged 40 or older, getting as high as 60 and not 77 as shown in the initial European patients. A female preponderance similarly, similar thrombotic location and thrombocytopenia, and the positivity for the PF4 with fatality of 25%. Next slide, please. And now that we understand the most common sites where thrombotic events are present, how would we recognize a patient receiving this vaccine and presenting with its complications? First thing's the timing, as we've mentioned 2 or 3 times now, that the risk of developing it would be between 4 to 28 days, and by far after the first exposure, in contrast to a second exposure of either one of these 2 vaccines. As we've mentioned before, and you see a depiction of the cerebrosinus venous thrombosis anatomically on the left upper part of your slide, and on the left lower part of your slide, you see this splanchnic venous tree throughout the abdomen. So you would have seen the main vein, the inferior vena cava, to which the veins bring in the blood drainage from all the abdominal organs, including the gastrointestinal tract, the liver, the spleen. They would all converge into the main highway, if you will, a 4-lane highway that will bring blood back to the right side of the heart. And this is the splanchnic tree. Next slide, please. The laboratory findings typically thrombocytopenia, most commonly of severe nature, consumption of fibrinogen, which is, if you will, a brick that will form a brick wall of a clot. So there is consumption leading to hypofibrinogenemia, and there's also increased destruction of thrombus that is being formed, leading to increased presence of pieces of the clot that has been broken down. These tests are called D-dimers. And next slide, please. One would need to prove the presence of a thrombus by ordering appropriate radiological imaging for the brain, computerized tomography with contrast called CT venography, or a magnetic resonance imaging with contrast called MR venography, or in the abdomen, an abdominal ultrasound, or computerized tomography with contrast, or magnetic resonance with contrast, the so-called MRV. Next slide, please. And the initial concept was that there were no clear risk factors. So pregnancy did not increase the risk for patients to develop this complication. Number 2, having an autoimmune condition did not set patients to have this complication. Having had a previous personal history of thrombosis or an increased family history of thrombosis, which include a history of stroke, heart attack in individuals aged 55 years or less, or females with 3 or more miscarriages, or a deep vein thrombosis or pulmonary embolism would not increase the risk for this condition. And finally, individuals exposed to estrogen-containing contraceptives, anticoagulants, or antiplatelet agents such as aspirin would not also be at increased risk of developing this condition. Next slide, please. The incidence, I'm afraid, if you pinch me down, I would have to continue to say is still unclear, but allow me to share some national database information with you. It is unclear because the rollout of the vaccination differs nationally. And secondly, the denominator of the types of vaccines to which different age groups would have been exposed also differs. So because of mainly those 2 points, we will be seeing slightly different numbers from different countries. Let's take a quick look at the numbers coming from the UK, for example, where intense scrutiny and surveillance has been occurring similarly to Canada. So post first dose ChAdOx, the incidence quoted around 1 in 67,000, and much rarer, as we had mentioned, almost 1 in 500,000 individuals exposed for the second time. If it was for us to break down according to age of the vaccine recipient, for individuals that are 49 years or younger, perhaps a prevalence of around, or incidence rather, of 1 in 50,000, and individuals 50 or older, 1 in 100,000. In Norway, the initial reports, very similar to the general UK, 1 in 60,000, and in the US, for the Johnson & Johnson Janssen vaccine, 1 in 500,000. Next slide, please. To put a Canadian spin and perspective, I took the liberty of looking at a report of COVID vaccines distributed. This doesn't mean administered, distributed in Canadian soil, a report generated by the manufacturers on December 16. And to put in perspective, the two adenovirus-based vaccines, the two bars seen on the right of your graph, the AstraZeneca and the Janssen, together do not sum up to higher than 4.2%. So this was, if we use the 1 to 50,000 to 1 to 100,000 incidents quoted from the UK, a calculation between 30 and 60 cases occurring nationally and in Ontario, somewhere between 11 to 22 cases. Next slide, please. Just playing with the numbers. These is probably a more contemporary look at how one can evaluate and risk stratify the patient you are seeing to have VITT or not. This has been published approximately 2 months ago on New England. It was a prospective cohort study conducted in the UK of all hospitals where patients would have been seen and treated with VITT during the summer of this past year. The criteria for one to call definitive VITT would that the patient would have all of the 5 findings identified in your slide, with a symptom occurrence between 5 and 30 days post-vaccination, except if the patient has isolated deep vein thrombosis or PE, when acceptance would occur as high as 42 days. Of course, radiological objectively confirmation of the thrombotic event, thrombocytopenia, elevation of the dimer, and a positive anti-PF4 with an ELISA-based test. Next slide. In the instance that one of those criteria would not have been met in the instance of timing or presence of thrombosis or the thrombocytopenia or the positive anti-HIT antibodies, this condition would now be called probable. Next slide, please. It would be called possible if the D-dimer levels was unknown, or if 1 or 2 criteria would not have been met. And next slide, please. It would be considered unlikely if, even though you still had a platelet count lower than 150,000, it would be in the absence of thrombosis or with a D-dimer that was not so elevated, or the thrombosis would have occurred in the absence of thrombocytopenia, regardless of the HIT screening assay diagnosis. Next slide, please. Let me allow to share so that we can put this in contrast to the initial description, and we still have 30 minutes of this prospective cohort to see if the initial perception, what are those pearls that will continue to remain? Next slide, please. This is a cohort out of almost 250 individuals, adults, all adults, that would have been seen prospectively in the UK, and the female preponderance that would have been seen initially would have disappeared, as 54% of the 220 patients included here, which had full VITT or probable hit, were included, or definitive hit and probable were included. And you can see that 170 had definitive and 50 probable. Visually, dividing them into the patients that survived and the ones that unfortunately died, we not necessarily see a difference from an age perspective and from a day of presentation after vaccination perspective. Next slide, please. To be more objective, the median age of those patients, of the 220 patients, would be 48 years, with the interquartile range shown between 18 and 79. And next slide, please. We have the median time after vaccination, spot on at 14 days, ranging between 5 and 48 days. Next slide, please. And next slide, please. Another way of looking at is that 85% of the patients that presented were younger than 60 years of age. And next slide, please. 97% of patients with definitive or probable VITT, which are the two, you'll remember the two higher categories, would presented after a maximum of 30 days post-vaccination. Next slide, please. The mortality was not as high as the initial 60%, and it was 22%, still tremendously elevated. Next slide, please. Let's now look at the laboratory features of these 220 patients with confirmed or probable VITT. And we can see on the upper left part of your slide, the median platelet count, 47,000, not as low as the 20 to 30,000 that was initially seen. We can see visually, perhaps, on the right upper part, on the patient's colored orange or ochre, that there may have been a preponderance of individuals with lower values for circulating fibrinogen. And on the lower part, visually, I don't think we can identify a tremendous difference of D-dimers on patients that remained alive versus had the death outcome. Next slide, please. And finally, 90% of the patients, remembering that 7% were not tested, had a positive ELISA screening, and only 3% had a negative ELISA screening or PF4 antibody. Next slide, please. In terms of thrombosis anatomical distribution, whereas initially the cerebrosinus was the one that concentrated the thrombotic events, we see a much wider array of presentations, as shown in your bar graph on the left part of your slide. So we see individuals with, had already been mentioned, lower limb, pulmonary arteries, portal vein, splanchnic veins, and adrenal vessels within the abdomen, and renal vessels. Arteries, these are new arterial events, arteries of the upper or lower extremities, coronary arteries being included, cerebral arteries being included, and other sites such as bowel and pelvic, retinal, and internal jugular. On the right part, just a graphic example of the classic CSVT shown in a CT computerized tomography with contrast on the upper part, and the lower part accompanied by parenchymal intracranial hemorrhage. Next slide, please. If we take a closer look to compare demographic or laboratory characteristics of the patients with that survived versus the one that did not, I perhaps can show to you, if you look at a median platelet count, a lower median platelet count on the individuals that died, a slightly lower fibrinogen level on individuals that died, a higher, slightly higher D-dimer level on the individuals that died. Next slide, please. If we look at univariable analysis to differentiate those two categories, again, alive versus death as clinical outcomes, there was an increased odd of individuals with CSVT to unfortunately have the outcome of death of 2.7 with the 95% confidence intervals portrayed. Number two, individuals that have equal or greater than 50% platelet count drop in contrast to its baseline value would have an odds multiplied by 1.7 of the death as the outcome. Similarly, individuals with a equal or greater than 50% fibrinogen level drop had an odds ratio of 1.7 with the confidence interval shown, and individuals that had increments of D-dimers by 10,000 fibrinogen equivalent units, which is one way of quantifying D-dimers, had also an odds ratio of 1.2. Those were the ones that were statistically significant. Next slide, please. The multivariable analysis showed that individuals that had CSVT accompanied by intracranial bleed and a platelet count equal or lower than 30,000, approximately 3/4 of those individuals would have had death as the outcome. And that was shown by the multivariable analysis on these individuals. Next slide, please. Why does this happen? I alluded to the fact that the pathophysiology resembled what is called autoimmune heparin-induced thrombocytopenia. Inside of platelets, platelets having its contents stored in two types of granules, dense granules and alpha granules. Alpha granules that contain platelet factor 4, which from an evolution point of view probably helped, gave platelets a defense mechanisms so that bacteria that was heavily negatively charged would be isolated by this compound. But be as it may, an intraplatelet content, platelet factor 4, would be formed when exposed to an excess of heparin, which is heavily negatively charged, and this works as an epitope, triggering an immunologic response. Autoimmune hit happens when a patient is exposed to minute concentrations of heparin. Next slide, please. The similarities of the pathophysiology of autoimmune hit thus seem to occur in individuals exposed to adenovirus-based immunized patients. What you see, this is a publication that is literally less than a month old. And it's a tremendous amount of work done by the German group led by Andreas Greinacher, who's one of the gurus of heparin-induced thrombocytopenia in the world. What ended up being shown is that adenovirus-based vaccines co-localize parts of its compounds with platelet factor 4 in the surface of platelets. What you see depicted on the upper left part in pink, you see the adenovirus based or derived compounds, and in green you see PF4 in the surface of platelets. And together, as they co-localize on the lower picture shown, it will attract to the right immunoglobulins of the subclass IgG that will react to this newly formed epitope. That's fact 1, or hit number 1. Not heparin-induced thrombocytopenia, I mean a hit. This is a 2-hit phenomenon. The second hit comes from the fact that I won't be able to share all the pictures. It's a lecture in itself. Adenovirus-based vaccine have products derived from its content. These are proteins that, in addition to EDTA containing those vaccines, will trigger a cytokine-related vascular leakage in an animal model. So it leads, this type of vaccines leads to an hyperinflammatory response. And if you put together the hyperinflammatory response associated with the newly created immune response, the antibodies against platelet factor 4, which comes because the epitopes provided by the adenovirus-based vaccine trigger it, you have an over-the-top response against platelet factor 4 mediated by this adenovirus type of vaccine. On the second half of the slide, you see cuts of thrombi extracted from cerebrosinus veins of individuals with VITT. On the pink part, you cannot see because it's too small, you see clusters of fibrin-rich and neutrophil-rich parts within the clot. And on the lower pictures, the mid panel, which are immune histochemistry panels, they are very rich in positive markers for DNA destruction related and coagulation cascade related parts within the clot. These are called netosis, neutrophils, and MPO. Next slide, please. So a summary of the pathophysiology is that there's a formation of VITT/platelet factor 4 antibodies that bind to heparin binding sites within the PF4 extracts released by the platelets that will now activate platelets, macrophages, and neutrophils. And this hyperresponse is potentiated by the presence of microparticles and netosis under the pro-inflammatory milieu created by the vaccine. It's a perfect storm. Next slide, please. How would one diagnose such individuals? Well, if you have a suspicion because of the signs and symptoms of the patient, you should start by confirming the presence or not of thrombocytopenia. And if there is thrombocytopenia, for you to move from presumptive to confirmed, you need to, 1, confirm objectively the presence of a thrombus, and 2, you have to send advanced tests. That would be the ELISA-based anti-PF4 test. To confirm it in Ontario, you should send plasma to the immune pathology lab at McMaster University. Next slide, please. How would these individuals be treated? These are evolving concepts. From the get-go, it was thought that because of the similarities with autoimmune HIT, these patients should not receive heparin or heparinoids. Similarly, because these are the platelets that are being induced to have a hyperresponse, despite the thrombocytopenias, these patients should not receive platelet transfusion. How would these phenomena or the thrombus be put at ease and arrest progression? They should be treated with non-heparinoid anticoagulants, which would, in the stable patients, encompass direct oral anticoagulants, and the unstable patients in whom either the renal or liver impairment would be present, they should receive parenteral direct thrombin inhibitors. There should also be immune modulatory initiatives such as the administration of IVIG or steroids or even rituximab or plasmapheresis, and these patients should immediately be reported to Public Health in Canada. Next slide, please. Let's, on the recent prospective cohort reported on the UK, compare what was utilized on the total cohort and on the more severe patients whose platelet count was lower than 30,000. And we can identify that many of such patients would have been exposed to heparinoids, but more commonly to the non-heparinoids, such as these may not be names that you're familiarized with, argatroban or bivalirudin or fondaparinux, or any of the 5 direct oral anticoagulants. And platelet transfusions would have been considered in patients that would have required neurosurgery or endovascular neurointervention, for example, and wouldn't forget to replace fibrinogen if that was the case. Next slide, please. Next slide, please. We have 15 minutes left, and I have just very few slides. And this slide summarizes the management algorithm of such patients for the definitives and the probable ones against, again, the immune modulatory initiatives such as plasmapheresis, steroid therapy, and IVIG, plus anticoagulant with a non-heparinoid agent. The intensity depending on the presence or absence of a bleeding, major bleeding rather, and the renal and liver impairment. And for the possible and unlikely, you see a different suggestion for the management algorithm 3. Next slide, please. This is a summary. Apologies, it's just for you to view the entire summary. This is what has been recommended by the COVID-19 Advisory for Ontario. Next slide, please. In individuals with either one of those symptoms depicted on your slide, the persistent and severe headache, focal neurological symptoms, seizures, blurred or double visions, and then symptoms related to the other thrombotic territories that would have occurred with the ideal timing. If the answer is yes, next slide, it would do the screening. Next slide, please. It would do the screening for thrombocytopenia, and if present, if absent, VITT is unlikely. If present, next slide, please. Then it would pursue the laboratory investigation with a CBC, in addition to the CBC, the D-dimer, the ELISA hit screening, and fibrinogen, and the imaging according to the complaint. Next slide, please. It's just a summary which summarizes exactly the same by ISTH. And this was in 45 minutes, a tour de force on the evolution of what has been described in VITT. Hopefully, we clarified and added how to appropriately name it. Next slide, please. And I will finalize with a pictorial summary or conclusion that it is a condition associated only to the 2 adenovirus-based vaccines against COVID-19, present in a small percentage of individuals exposed to it. Unfortunately, it continues to be associated to a high mortality, particularly individuals with cerebral sinus venous thrombosis, with intracranial hemorrhage, and severe thrombocytopenia. Next slide. I thank you for the opportunity of sharing these concepts with you. Thank you for your attention, and the floor is open. Thank you. Thank you, Isaac, and thank you, Upton.
Yeah, thank you so much. That's fantastic. We really sincerely appreciate it. Leo, let me start with a few questions. And the first question I have is, are there individuals who are predisposed to this by virtue of genetics and ethno-racial backgrounds?
Fantastic question, Upton. As we understand more and more of the pathophysiology, I wouldn't be surprised if we start identifying who are the individuals that may be more likely to co-localize the new antigens that will trigger the antibody response, meaning not everybody that receives an adenovirus-based vector vaccine will be able to co-localize PF4 in the surface of platelets to trigger the formation of the immunoglobulin of IgG subclasses, because that's what happens in patients with HIT. And I suspect over time we may gain clarification on what would those risk factors from a genetic background be. As it may, because we're just in that initial phase, the short answer would be no, or we are still to have it clarified. But as this 1 month old publication just really launched a new light on the pathophysiology, I suspect the answer may change in a short period of time.
That's great. Thank you so much. And my second question for you, and others can put their questions to us through the Q&A. Leo, is let's say you have a 40-year-old, 50-year-old individual who's previously had a stroke, cerebrovascular accident. Do you see a problem with them getting an mRNA vaccine?
I do see a problem if an individual does not get any type of vaccine in the world. Upton, we are seeing that, I mean, I'm sure this has been discussed in the program. We are seeing what Omicron is a consequence of us not being able to have a more equal distribution of vaccination globally. And thrombotic complications are by far much more common in individuals with acute COVID, particularly of moderate and severe presentation, than in any of the quotes of incidents that I've shared with you today of 1 in 50,000 or 1 in 100,000. Thrombotic complications can occur as high as, in some literature reports, as high as in 70% in severely critically ill adults admitted to an intensive care unit. So I would pledge that receiving any type of vaccination to prevent that consequence would by far prevent thrombotic complications. Individuals, now zooming in your example of an individual with a previous stroke, clinical risk factors for stroke in young adults are not different than what we are familiarized with. It's a combination of our sedentary lifestyle with cholesterol-related issues on the arteries. So that, as today, and given the pathophysiology I've just shared, would not be considered partial or even contraindication for one to receive vaccination. I don't know if I answered you.
No, that's right. I mean, do you make any distinction in that regard, in that scenario, between receiving a vector vaccine versus an mRNA vaccine?
Excellent question. If the adenovirus is the only one you have available, I would go for it.
Okay, that's good. Let me ask Dr. Adami, Isaac. Patients with sickle cell disease have a propensity for various types of thrombotic type events, pulmonary, for example, cerebrovascular as well. What advice would you give as this relates to the COVID vaccines, mRNA versus vector, recognizing that most people with sickle cell disease don't live in North America where we have the mRNA vaccines available?
Yeah, absolutely. I think I will give the similar answer to what my good friend Leo has, that the risk of thrombosis associated with COVID disease is so high compared to vaccine-induced thrombotic risk. And given that sickle cell disease patient, COVID being a respiratory virus primarily, sickle cell disease patients don't do well with respiratory viruses because of their propensity to develop acute chest syndrome and severe hypoxemia. So based on all that, our recommendation globally is that they should take any vaccine available, given that most areas where sickle cell patients live are the very areas where access to vaccines can be a problem. And so the recommendation from certainly the Global Sickle Cell Disease Network is that any vaccine they can get access to puts them in a better position than contracting COVID.
Oh, that's great. Thank you so much. And I guess another question I have is, Leo, how might you explain differences in rates across age bands, across age groups?
Thank you, Upton. Excellent question. The initial difference is that, I mean, the thrombotic complications, let's look globally. 1 in 4 individuals living in the developed world die of a thrombotic cause. Again, I'll go back to a combination of lifestyle, sedentary, and food habits. In the past, I play when I'm talking to the patients, we had to literally run and fight to have lunch. Nowadays, we just put a coin in the machine to use the extreme, even though the Japanese and individuals that live in the Mediterranean are the ones that live the most in the globe. So it's not a good example. In Japan also, you can buy absolutely everything on those box machines. But my point is, we don't need to have the cardio workout to get lunch anymore. And a combination of that has led to this figure of 1 in 4 individuals dying of a blood clot in the developed world. This relates to adults. In children, thrombotic complications are somewhere between 100 times to 10,000 times less common in comparison to an individual aged 70. It's even higher, 100,000 times at least on individuals 75 and older. So regardless of Botox or of how we portray ourselves on social media, we cannot fool our thrombotic tendencies. And because at every decade at the age of 40, our clotting factors go up. That's physiology, unfortunately, or fortunately. I don't know if I answered. I gave a lot of metaphors, but to try to put in perspective that thrombotic complications, that would be a much more succinct and clear answer. Thrombotic complications are much, much more common in the adult population. And perhaps if you put together the pro-inflammatory milieu caused by the, or seemingly caused by the adenoviral related vaccines, together with a much higher thrombotic tendencies that adults have, this may explain the differences, even though I was able to show the difference on individuals aged 50 and higher versus less than 50, and there was a twofold difference between them in the UK. It would be very nice if we had, according to decade, a difference of, I'm sure it's thrombosis is not the only answer here. There may be an immunologic difference in response according to age group. There may be an this word ethnic is becoming less and less appropriate, Upton. This past week, I've just heard that the concept of ethnicity, how it is genetically, if we look at differences, there's less than 0.0001, or what I'm trying to say is, I was going to say ethnically there may be differences, but I was invited and continue to be invited to evaluate that concept. And therefore, I'm just sharing my uncertainties rather than certainty that ethnicity plays a role as well. So hopefully I answered you.
Oh, no, thank you so much. It's really a wonderful presentation, great discussion. And I want to thank you both and thank our participants, and stay tuned for the announcement regarding the next session. And please remember to complete the evaluation. So thank you very much, Leo. Thanks, Isaac. Have a great day.
Thank you. Bye-bye.